So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, in collaboration with Lily, is organizing an educational activity entitled Novel CGRP Monoclonal Antibodies in a novel recipe for success in migraine prevention and treatment. Why we are talking about anti-CGRP? Because the therapeutic options for migraine have recently been expanded, particularly due to the clinical development of drugs targeting the action of calcitonin gene-related peptide, CGRP. And among the developed anti-CGRP is galcanezumab, a humanized monoclonal antibody that demonstrated good safety and efficacy profile in treating and preventing migraine headache and was actually associated with improved health-related quality of life in its phase 3 clinical trials. Before introducing our first migraine expert, let me thank Lily for sponsoring this educational activity. In our first session, Dr. Serai, joining us from the UAE, will discuss the safety and efficacy of galcanezumab in both the clinical trial and real-world settings. Dr. Serai has got his medical degree and master's degree in neurology in the Republic of Belarus. He worked as a head of neurology and psychiatry department in military and police medical service in Belarus. After moving to the UAE, he had extensive neurological experience working in public and private hospitals in the UAE. He has particular interest in diagnosis and management of headache disorder. Dr. Serai, we are really honored to have you as a speaker with us tonight. Welcome, and the floor is yours. So we are seeing your slide perfectly. You can go.
Good evening, everyone. Thank you very much, Dr. Maya, for your nice introduction. It's my honor to speak with you regarding our big topic, which is very important in our neurology field. So we will be talking today about neural treatment of headaches, particularly migraine. What is migraine? This is my disclosures. What is migraine? It is genetically predisposed chronic debilitating neurological disease characterized by recurrent attacks of probing headaches of moderate or severe intensity with uni or bilateral location, lasting usually up to 72 hours, aggravated by or causing avoidance of routine physical activity, and usually accompanied by nausea or vomiting and excessive sensitivity to light or to sounds. So what about statistics of migraine? Sorry. It's the most prevalent of all neurological disorders. Migraine is the most prevalent. So a majority of our patients in our clinics are with patients with migraine. This is the 5th most prevalent disease worldwide, the 6th most disabling disorder, rising to the 3rd in the age group under 50s, and with global prevalence up to 12% of population. You can see here in the slide that 1 billion people worldwide are suffering from migraine. So this is the 2nd overall cause of years lived with disability, and it is a leading cause of years lived with disability in women of 15 to 45-year-old. So as we can see here, it's more frequent in 3 times more frequent in women, and of course it's quite frequent in children. So when we talk about migraine, we are discussing about disability, and here also you can see how significant impact migraine makes to the family life, to interaction with spouses, to interaction with children, to parenting of children, and to be able to perform housework and so on. Apart from this, migraine is associated with quite significant decrease of work productivity. So people are missing work or school. People are not able to make a good performance, and all of this causing substantial loss of productive time. So let us talk about a little bit about some types and subtypes of migraine. So majority of patients, 80% of patients has migraine without aura, 20% with aura. So what aura we usually see in our patients? This is visual aura. It's depicted here. So it could be sensory aura, sensory symptoms. It could be speech and language difficulties, could be motor aura or brainstem aura. So there are some uncommon types of migraine. And there is a complications of migraine. A majority of complications are status migrainosus or migrainous infarction. Migraine is coming, usually have phases. It may develop in stages, so evolving over hours and lasting sometimes days. The pain phase is one of the phases that characterized a migraine episode. Typical migraine attack consists of 4 phases or components. First is prodrome, usually can last within few hours to few days. The next is itself aura, which usually lasts less than 1 hour. The next most debilitating phase is itself headache itself, which may last, as we said, up to 72 hours. And there is a post-drome or post-headache phase when patient is recovering from usually from migraine attacks as well, and from side effects of medications also. Also, we are dividing migraine to 2 subcategories. This is episodic migraine. Vast majority of migraineurs are having episodic migraine, around 90%, and the rest is a chronic migraine. Episodic migraine usually occur 14 or less days per month, and more than 15, these are chronic migraine. So, as we said, migraine is a disabling disorder. How we assess disability? So, we usually use different scales, but one of the most popular is a scale called MIDAS, Migraine Disability Assessment. So here we are seeing how many times, how many days patient miss work or school, how many days he was not productive while he was visiting school, how many days patients keep performing household activities, and the same regarding productivity, and how many days patient miss some leisure or family activities. And accordingly, we are calculating. So when we receive the patient in our clinic, when we diagnose migraine, we usually go to 2 to 3 strategies. The strategy number 1, part number 1, is a lifestyle modifications and trigger management. Part number 2, of course, this is acute therapy for migraine. This is a specific or non-specific migrainous medications what we are using for attack management. And most important regarding our talk today is a third part, is a preventive therapy. What we have to achieve when we are preventing migraine? This is a reduction of frequency, severity, and duration of migraine attacks. This is an improvement of responsiveness of our patient to acute medications. This is improvement of function and reduction of disability, improvement of health-related quality of life, and of course, reduction of cost associated with migraine management. So here you can see that migraine prevention is significantly reducing, proper migraine prevention can significantly reduce visit of emergency, the need for performing CT or MRI, the need for performing some other tests. Who need migraine prevention? According to American Headache Society updates of 2021, so patients who need migraine prevention usually have attacks that significantly interfere with their daily routine activities despite of acute treatment. Frequent attacks, more than 4 migraine monthly migraine days. Patients who have some failures or overuse of acute medications for migraines, significant adverse events with acute treatments, and last and not the least is a patient preference, of course. Also, we should consider migraine prevention in patients with hemiplegic migraine, migraine with brainstem aura, migraine with prolonged aura more than 60 minutes, and in patients with a history of migrainous infarction. So it is estimated that nearly 40% of patients with episodic migraine and nearly almost all patients with chronic migraine would benefit from preventive treatment. And here you can see, the big pathway protocol, how we are usually treating our patients with migraine, how we were treating our patients with migraine up to 2018. But the problem here you can see our so-called traditional or conventional older oral prophylactic medications, including different classes of medications. This is beta blockers, ARBs, antidepressants, anticonvulsants, calcium channel blockers are adopted from alternate indications. They are not designed specifically from the beginning for migraine. Many of them have limited to moderate efficacy and or moderate to high rate of adverse events, contraindications, and interactions with that significantly limits their use and leading to dissatisfaction of big majority of patients. This table is showing some examples of frequent contraindications, precautions, and side effects of medications. So, as we can see here, we have a problem. So we need to prevent migraine, but there are some studies, surveys that showing that at 60 days of preventive treatment with our so-called standard of care, which I don't think we need to call it standard of care at the time being, we will tell you why. So nearly 50% of patients are discontinued the treatment by the 2 months of treatment, and just only 11% of patients are remaining on preventive treatment by the 6 months of treatment. So let's go to our today's drugs. So the understanding of migraine pathophysiology significantly evolved over the last decades. It's believed that activation of trigeminal vascular system is playing a very significant role in migraine pathogenesis. Migraine patients during attacks have significantly increased serum, saliva, CSF concentration of specific substance called calcitonin gene-related peptide. And this CGRP is released from terminals of trigeminal ganglia. And when bound to its receptor, it's responsible for a cascade of events that are causing neurogenic inflammation, vasodilation, mast cell degranulation, protein extravasation, and other reactions. So, along with understanding migraine pathogenesis, migraine management has also significantly developed over the past years, with the release of new biologics that have been developed and designed specifically to target CGRP. So now we have a specific treatment. specific migraine preventive treatment. So CGRP antagonists are humanized or human monoclonal antibodies, biologics that bind to CGRP ligand molecule itself or its receptor and block its binding activity, selectively resulting in inhibiting of this cascade of reactions what we have mentioned previously. Worldwide, we have now 4 medications, 4 biologic: alkanezumab, remazumab, eptinezumab. They are humanized, and they are molecules which are binding to CGRP ligand, and one is called erenumab. This is a CGRP receptor blockers antibody. So today we are talking about a medication called galcanezumab. It's an IG4 monoclonal antibody indicated for preventive treatment of migraine in adults, both types, episodic and chronic. So it's designed to target CGRP ligand or molecule. It acts peripherally in structures involved in migraine headaches pathogenesis, including mainly trigeminal ganglia. So let's go to a real case, what we have in our clinic recently. This is a patient with a 26-year-old female. She is unmarried, IT specialist in a bank. She has a past medical history of irritable bowel syndrome. She has a strong family history of migraine. Her headache started, you can see, at the childhood. Her headache is pulsating with aura, bilateral or usually unilateral. So quite severe, 7, 8 out of 10. And she has to visit from time to time, at least once per month, emergency. So quite frequent. It's a high frequency episodic migraine with nausea, photophobia. There are some triggers. She is benefiting from sleep in dark, quiet environment, partially relieving her headache sometimes. So she's on brufen, naproxen. We combined with sumatriptan as an acute treatment. So as I said, she has to. She's getting from this acute oral treatment just partial benefit. She has to visit ER at least once per month, usually with good response. And previously, she tried many different medications, what we mentioned, for migraine prevention: beta blockers, antidepressants, anti-epileptics, and calcium channel blockers. Unfortunately, she could not benefit from this preventive treatment because of side effects and inability and insufficient response. So she came recently she came to our clinic after just finishing 6 weeks a trial of flunarizine with no significant benefit. She had normal neurological exam. She has done MRI brain several times, MRV, MRA, because her parents were worried why she is getting headaches despite of different preventive treatment. So she has 12 migraine headache days per month. Her MIDAS score is quite high. Recently, she missed 4 days of work, and some family events. She has to come to emergency twice. She was quite disappointed regarding options for treatment. So she is quite a strong candidate for migraine prevention. She needs an agent with rapid onset of action without any impact to her ability to work, preferably without dose titration. As I forgot to mention, so for all preventive treatment, we have to titrate medications, for sometimes weeks, sometimes even months to get some proper dose. But usually before reaching the proper dose, patient is discontinuing this medication because of side effects. So she needs medication which is starting from effective dose with simple administration and helping her to be compliant. So our new treatment, CGRP, monoclonal antibodies are fully meet of our requirements. So we started her on galcanezumab. So as you can see here, follow-up at month 1, she had significant reduction of migraine headache days from 12 to 3, more than 75%. So effect was noticed from the first week of initial lighting dose. So she reported about 2 attacks only that never happened before from the age of 13. Severity of headache remained the same, but they were well respondent to non-steroidal inflammatory medications within much shorter hours than before. She had no side effects from treatment. Follow-up at month 3, 1 attack per month, with a fast response to brufen or paracetamol migraine. Few mild episodes of tension type of headache. And follow-up at month 6, on average, she has just 1 mild attack per month, and she did not take any analgesics. So we can see quite significant, up to 75% of reduction of migraine headache days. So what about safety and efficacy and safety of galcanezumab? So it was evaluated in 4 phases 3 studies for both episodic and for chronic migraine. There were 2 EVOLVE studies, EVOLVE 1, 6 months double-blind study in North America, EVOLVE 2, 6 months, same design, but it was global study, North America and Europe and some other countries. There was a 3-month study called REGAIN for chronic migraine, and there was a study, 1-year open-label safety study for episodic and chronic migraine with global precipitation. So if we can see this graph, where galcanezumab showing significant reduction of number of migraine headaches days versus placebo. So it's a phase 3 randomized double-blind placebo-controlled trials which found statistically significant and clinically meaningful mean reduction of monthly migraine headaches days compared to placebo in patients with episodic migraine. So in both studies, EVOLVE 1 and EVOLVE 2, galcanezumab was superior to placebo in reducing the mean number of monthly migraine headache days, as you can see here, across the 6 months of the double-blind study period. Both EVOLVE 2 and EVOLVE 1 and EVOLVE 2 studies provide further class 1 evidence for use of galcanezumab in prevention of episodic migraine. In terms of galcanezumab, one of the advantages is that given a lighting dose, 240 milligrams, helps to achieve a peak serum concentration much faster comparing to single dose injection. So please pay attention to this slide that is clearly showing the rapid onset of efficacy of galcanezumab for prevention of episodic migraine in these 2 trials. So for both of them, change from baseline, you can see here, in monthly migraine headache days shows a statistically significant separation of galcanezumab arm from placebo arm at month 1, and each subsequent month, you can see here also. Analysis of the first month for both studies indicate onset of effect in the first week and each subsequent week compared to with placebo-treated patients. So in addition, in nowadays, we know that due to high rates of patient non-adherence to oral migraine preventive medications, early onset of effect is quite important feature to consider when we prescribe preventive treatment. Another slide showed another interesting fact, that galcanezumab showed efficacy as early as day 1 following loading dose in the treatment of migraine with episodic as well as with chronic migraine in EVOLVE 2 and REGAIN studies. We know how difficult to treat patients with chronic migraine, but these graphs, we can see here by these graphs, that we can expect the galcanezumab to be effective not after 1 month, not after 1 week, but within the first day and days of treatment. You can see by these graphs. Galcanezumab is the only CGRP monoclonal antibodies with documented 75 as well as 100% response rate as a pre-specified secondary endpoint in clinical trials for patients with episodic migraine with episodic migraine. You can see in this slide about 26% at month 1 of 75% response rate in 26% of patients, and this response was increased with treatment each month up to month 6 of treatment, achieved 75% response rate, almost in half patients by month 6. Another interesting fact from the data is that response rate to galcanezumab is not only documented at month 1, at month 3, at month 6 of treatment, but it showed sustained, consistent response week after week, month after month, week after week, and month after month. Yeah. So with galcanezumab, patients does not experience any wearing off effect of monthly injection after 3 or 4 weeks following injection before next injection. So it's showing by this data. So let's go to case report number 2. This patient with a chronic migraine. She is 41-year-old female, housewife, mother of 4. She has a past medical history of hypertension, well controlled on 3 medications. She has a family history of migraine. Her attack started at the age of 15. Throbbing and pulsating, throbbing and pressing quality. Headaches are uni and bilateral, quite severe in intensity. Also, she has to visit quite frequently emergency department for IV analgesia. So frequency of migraine headache days, 17 to 20, depends on the month. There are some associated symptoms of nausea for the 4 days. She cannot specify triggers. Sometimes sleep helps. Daytime nap sometimes helps. So she is missing family events 3-4 times per month and not able to do household activities for at least 5 to 6 times per month. So she tried. This is a patient with chronic migraine. She tried everything, even valproate. She got some response from valproic acid, but she stopped it because of weight gain. She tried even this Cephalid device for trigeminal nerve stimulation, but only mild benefit with acute treatment and no benefit for prevention. She tried Botox, but she stopped it because it was not effective after the 4th session, and she could not tolerate the pain because of injections. Because you know, Botox we have to inject at least 33 points each session. So she has to use a lot of paracetamol, non-steroidal, triptans, and she came for follow-up following after 2 admissions over the past 6 months to hospital due to status migrainosus. So for inpatient management. So her investigation, her exam and investigations were unremarkable, and she was quite depressed because she didn't get any benefit from the treatment, and because of she is a part of medication overuse headache as well, and we advise her to get some detoxification program to stop acute medication overuse, but she was quite reluctant because she was afraid of this recent experience with status migrainosus, and she was very hesitant to start any new treatment. We were also not very optimistic. But anyway, so she refused to get occipital nerve block because of painful experience with Botox. So she was informed about our new drugs. So she came back to us with a will to start galcanezumab. So she received loading dose in our clinic. So loading dose is two pre-filled pens, 120 milligram each. This is 240 milligram total dose. So month 1. So she came after 1 month. It was like a magic, fast, dramatic response. No headaches from day 3 to 10 following loading dose. 5 migraine headache days are thereafter. About 75% decrease in migraine headache days. Months 2, 4 migraine headache days, which is managed by Brufen. She did not use any triptan. So months 3, 5 migraine headache days. And you can see months 9, 4 to 5 migraine headache days on average. So she forgot to inject the ACE dose, and she was, because of significant reduction of migraine headache days, she got some mild increase in frequency, but she was managing her headaches with paracetamol only. So apart from decrease of migraine headache days, no more ER or inpatient admission, significant decrease of pain, persistence, and severity, so and decrease of disability. So next data showing efficacy and safety of galcanezumab in prevention of patients with chronic migraine. The data from REGAIN study, it's a double-blind, placebo-controlled, randomized clinical trial, it's quite impressive. What we can see here, it's at baseline nearly 20 monthly migraine headache days. That mean a reduction in headache days was statistically significant and far superior from placebo with reduction of about 5 days per month. So the right graph you can see here shows us that response was not only dramatic in the first month, but also sustained during all months of trial. This is 3 months trial, showing improvement in each month after previous months. And in addition, this response was already very significant here after first month of treatment, showing good separation of placebo arm from galcanezumab arm. So it means we don't need really to wait and expect improvement after many months. So we can expect it within the first months. Let's go to safety of galcanezumab. So this slide is showing us the tolerability and safety and compliance to treatment with galcanezumab. Up to nearly 90% of patients with episodic migraine and phase 3 of EVOLVE-1, EVOLVE-2 trials, and 95% of patients in phase 3 of REGAIN trial completed their studies. So you can see over 2,500 patients involved. Only less than 2% of patients discontinued treatment due to side effects. Less than 0.5% of patients discontinued treatment due to injection side reactions. There were majority of the patients, they were not significant if occurred on day of injection and resolved in the next day, not leading to any discontinuation of treatment. And above 80% of participants have said that they experienced less impact from side effects compared to previously tried preventive treatment. So which is also showing here in phase 3 long-term open-label safety study of galcanezumab in patients with both types of migraine. The study evaluated the safety, tolerability, as well as effectiveness of galcanezumab for up to 12 months of treatment. It confirms same results as EVOLVE-1, EVOLVE-2, and REGAIN. And we can see here dramatic response in the terms of statistically significant decrease of monthly headaches days, monthly migraine headache days during the first months of treatment. And that was maintained and showing subsequent reduction of migraine headache days through all 12 months period of the study. So therefore, results from the study confirm the long-term effectiveness as well as safety of galcanezumab in patients with migraine. So who are eligible for treatment with CGRP monoclonal antibodies? According to American Headache Society consensus statement, so patient should be at least 12 years of age. Patient should enable to tolerate 8-week trial at specific established doses of oral previous preventive, at least 2 medications, or on botulinum toxin A injections for chronic migraine. And it's supposed to be some disability, which you can see here. Same was in guidelines, sorry, from European Headache Federation until recently. So patients should have 2 failed trials of oral preventive medications. But now, in this year, we got an update of European Headache Federation. So that is showing us expert consensus statements. So indicating, stating that in individuals with migraine who require preventive treatment, we suggest monoclonal antibodies targeting the CGRP to be included as a first line of treatment option. And we should pause the treatment with monoclonal antibodies after 12 to 18 months of continuous treatment. If deemed necessary, treatment should be continued as long as needed. And in individuals with migraine who pause treatment, we suggest restarting the treatment if migraine worsens after treatment withdrawal. So it's quite promising guidelines. Why? Because, as we said, in nowadays we are considering CGRP and monoclonal antibodies as a standard of care, but previous oral medications, we can say it's a substandard of care. So it's quite easy to use. First months, we are injecting initial dose, 2 prefilled pens, 120 milligram each. And from months 2 and onward, one pen per month. So there is a quite good adherence to this treatment, you can see here, according to this data. And these are sites where the patient usually injecting. This is back of the upper arm, abdomen, or anterior thigh. So I just want to conclude my talk. So these last 2 slides that are summarizing what we have said about the use of galcanezumab in preventive treatment of episodic and chronic migraine. So galcanezumab shows clinically meaningful and statistically significant reduction of monthly migraine headache days versus placebo in all migraine patients, with high response rates across the patient population in terms of migraine headache days. So also it showed early onset of effect as early as day 1 after first loading dose of galcanezumab. So maintain efficacy and safety. It showed and maintain efficacy and safety throughout each month with sustained effect up to 1 year, and quite favorable safety profile and easy to use prefilled pen with no needed for any titration. Thank you very much for your attention.
Thank you, doctor, for a great overview about migraine, its a treatment, anti-CGRP and galcanezumab in particular. And please allow me to take some questions. So the first question, which is the preferred anti-CGRP for pregnant women? So we know that there is no study performed on pregnant women for anti-CGRP and galcanezumab in particular. But as you know, galcanezumab have shown no embryo fetal side effect in animal trials. So do you prefer to use it on a pregnant woman, or do you prefer sumatriptans?
No, we don't use it so far. There is no clear safety data to use in pregnant women. So we usually, in case of planning of pregnancy, we usually ask patients to discontinue, 3 to 4 months before conceiving. And in case of if patient detected to be pregnant, we just advise to stop it.
And what is the alternative treatment for migraine in pregnant women? What do you usually, how do you usually treat a pregnant woman with migraine? Usually stop all treatments?
No, we can, usually, as you know, during migraine, there is a possibility of some patients are going to relapse of migraine. Some patients are going to kind of remission. So we can use triptans, We can use non-steroidal, but during not the first of trimester of pregnancy.
Yeah.
Yeah. So we cannot use, unfortunately, majority of oral preventives, especially anticonvulsants, which are class C, class D in pregnancy.
Another question, Halima is asking that she's actually diagnosed with thyroid malignant cancer, and she do complain of chronic headache. So if there is any relation between thyroid cancer and headache attack and migraine headache attacks?
Not really, because you know, migraine is quite separate disorder, and it's clinical diagnosis. Patient should fulfill some specific criteria, what we have mentioned above, you know, and definitely when naive patient comes to our clinic with headaches, we have to exclude some secondary headaches. That's why we are using neuroimaging studies, not to confirm migraine, as we said, but just to include some other causes, structural causes of headaches. So in such situations, most likely she has a migraine, but she has to be evaluated by neurologist to exclude less possible structural causes of headache and to start migraine preventive treatment.
And another question, do we use anti-CGRP and galcanezumab in particular as add-on therapy with other anti-migraine therapy, or no, it is indicated to be used as monotherapy?
No, we can use it. We have some patients, but there are not many, where we are using CGRP, monoclonal anti-CGRP monoclonal antibodies, and let's say amitriptyline. Some patients with a chronic migraine, they are using anti-CGRP, and they are afraid to stop. Sometimes, in case of not very adequate response, they are afraid to stop using Botox. So it's not contraindicated. It can be, but usually majority of our patients, they are benefiting significantly from monotherapy related to anti-CGRP monoclonal antibodies. Yeah.
And the last question, the safety of galcanezumab was well demonstrated in its phase 3 clinical trial. However, from your clinical practice, what are the common side effects that you usually encounter with galcanezumab? Usually with other anti-CGRPs, we are dealing with constipation, injection site reaction. So what is your experience or your input for galcanezumab in real-world clinical practice?
We have many patients on galcanezumab, but what I have noticed only injection site reaction, and usually brief, just pain during injection, just some redness, some edema, which is disappearing within a very short period of time. So I have never ever noticed with my patients any other side effects.
And we have one final question about the role of Botox in treating migraine. Why it is effective and when it is indicated in the management of migraine?
Yeah, Botox is indicated for treatment of chronic migraine only, along with topiramate. Rather than until recently, it was just two medications which are indicated for treatment of chronic migraine. There is some data showing that somehow botulinum toxin is also influencing CGRP pathway, but there are some many theories that are not very clear regarding the Botox mechanism of action. But somehow it's influencing CGRP pathway, trigeminal system.
Yeah. Thank you, Dr. Serai, for joining us tonight and for an enriching session. We will move to our second lecture. Thank you. And our second speaker is Dr. Marlene Bijani. who will explain to us the differences between the different anti-CGRP available on the market. And most importantly, she will highlight on the World Pharmacist Day, which is today, the role of the pharmacist in the management of migraine headache. Dr. Marlene Bourjani Mukarzel graduated with Doctor of Pharmacy degree from St. Joseph University, Beirut, Lebanon in 1994. She is double board certified as pharmacotherapy and as nutrition support specialist. She is also certified practitioner in health equality. Currently, Dr. Marlene is the pharmacy manager at Sheikh Shakhbout Medical City, a joint venture between Saha and Mayo Clinic, and the largest tertiary hospital in the UAE. Thank you, Dr. Bijani, for accepting our invitation tonight and for being with us. Please, you can start your presentation.
Thank you, Maya. So, good evening, everyone. Delighted, as usual, to be with the IVPN group and to talk to this many pharmacists, physicians, nurses. I was asked to talk about the CGRP antagonists and if they are all the same. But those are treatments for migraine prevention, or we can see in the presentation for treatment also. So I thought my passion is more into what the pharmacist should know about a disease, what the pharmacist should know about a group of drug, what are the counseling tips. And that's how I have prepared this presentation. And I hope that it will be helpful and you will learn something from this presentation tonight. While preparing, I have asked, I have asked the group of pharmacists I work with, if I tell you migraine prevention, what is the first thing that comes to your mind? And to my surprise, only few of them, only three, mentioned the CGRP inhibitors, while it has been a while that we have those drugs in our formulary and available for our patients. And still everybody, most of the answers came for propranolol. So I thought that yes, it is, it's very important to have this presentation and maybe even to repeat it for pharmacists so they can be aware of those new group of medication and this new treatment. So I wanted you to know that I'm not a neurologist. I'm not also a neurology clinical pharmacist like Maya. I'm very impressed by Maya's specialization. I was an ICU clinical pharmacist before I became the pharmacy manager, but I'm a mom and one of my daughters has a kind of migraine. I will just give her as an example in later on. My sister had migraine, and not only one friend, I have a few friends around me with migraine. So the topic is interesting for me, and I think it is interesting for you, even if you're not working as ambulatory pharmacists. Definitely you have around you friends or family members that have migraine. So I will be discussing quickly the abortive and preventive treatment of migraine and the pharmacist role with migraine patients. And at the end, I will give some comparison among all this group, the CGRP antagonists. This was mentioned, I mean, speaking migraine, it's either lifestyle or acute therapy or preventive therapy. And I'm not going to talk about lifestyle and trigger management. I will go through the acute therapy and then the preventive therapy. So what do we give to a patient with migraine? And now we are speaking about the abortive, the acute therapy. It's either the simple analgesic or the non-steroidal anti-inflammatory, the triptans, or some kind of ergotamine or a combination. This slide was based on a reference from 2015, and since then there was a new drug, the lasmiditan, which is a 5-HT1F receptor agonist. So it's different from the triptans by the site, which is 1F instead of 1B, 1D. And it can be given when the triptans are contraindicated because of cardiovascular risk, because it doesn't, and I will show you the mechanism of action. And something important to know is that some of the CGRP antagonists can be used for abortive treatment of migraine, not only prevention. So the contraindication of triptans, I am mentioning it here, and I don't want to overlap with the first presentation, but we all know that they are contraindicated with those diseases. And sometimes there are non-respondent for triptans, and you can switch from one triptan to another one. You may have some effect. So the new agent, as I said, the lasmiditan, and new CGRP antagonists, those are tablets, the rimegepant and the ubrogepant, and those are tablets that are also antagonists of the CGRP. Now, that's how, just for you to memorize, you can see that the only 5-HT1B receptor is on the blood vessels, and while the 1F is not on the blood vessels, and that's why if you are, so the 1B is the only one causing vasoconstriction, while the 1F will not, and that's why the new medication is not contraindicated in coronary diseases. So how do we treat migraine, like the abortive treatment, the acute treatment? Either with triptans, with analgesic, and there is something very important, is that opioids and tranquilizers are not recommended by guidelines. It's very important to know that we should not allow our patient, and we should counsel our patient about overuse. Triptans should not be used more than 9 days per month. The simple analgesic, not more than 15 days per month. And the combination, not more than 10 days per month. And if your patient reach those levels, it means you can advise your patient to reach to a neurologist and maybe start a preventive treatment. A topic that I am very passionate about is even paracetamol. That is, people will think that it is the safest drug. Paracetamol overuse can lead to a liver failure. I have seen, we have lost one of our friends because of liver failure, because of overuse of paracetamol. So overusing medications is always not recommended, and we have to be vigilant when we counsel our patient, when we discuss with them while dispensing their medication. In real life data, you can see that still opioids, while they are not in the guidelines, they are still prescribed and used for migraine treatment, and which is not in the guidelines. And I want you to make sure that you know this information. So what is important when you are counseling a patient while giving him a triptan or a combination analgesic? The patient should take the medication early, and the patient should take a large single dose, so it will work, not a small repetitive dose. And if I will go to the example of my daughter, I do not give her diclofenac 50 milligram with paracetamol when she has an attack. She right away will go to 100 milligram of diclofenac suppository, and thanks God, this is helping her, and that's how she managed her migraine. We didn't reach the threshold of 9 or 10 days of migraine attack per month. So as you all know, there are non-oral route, because migraine would cause vomiting, nausea and vomiting. There are non-oral routes that can be used, rectal or nasal routes, for those medications. So I spoke about overuse. So what do I mean by overuse? So I kept this in one slide to show it to you. So we cannot speak about migraine without speaking about MOH. And what is MOH? Is it Minister of Health? No. So MOH is medication overuse headache. And I already alluded to that a patient taking more than 15 days per month a combination medication, or more than 9 days of triptans, this patient has a medication overuse headache. and should seek attention. The treatment should stop. Other treatments should start. Triptans can cause medication overuse headache. So we have to be very vigilant. And that's where preventive treatment should start to be thought of, or the patient should be prescribed preventive treatment. I'm sorry, cannot see the. So when do we give prevention? So we reach the prevention. When do we give prevention? It's mentioned that it's frequent or long-lasting with migraine headaches, and I will discuss this a little bit later. When there are failure to therapy, when there is risk of medication overuse headache, and in menstrual migraine, because it's clear when the migraine will come. I'm not sure, I cannot move the slides. Okay, so when we read about it, what is the criteria, when to start prevention? You can find different references, more than 6 per month, or more than 4, more than 12 hours of pain. And I conclude while reading a lot about this, when to give the prevention, that there is no strict definition, and it is a clinical decision. The decision should be between the physician and the patient on how much the patient can afford to have, how many days he can afford, how many hours, and the decision should be taken at the clinic between the physician and the patient. And also there are other things that the previous presentation discussed on when we can use the prevention. So something very important is that when we use the prevention, that prevention will reduce the attack frequency, severity, and duration, but it will not totally remove the migraine. I mean, the patient will still have some attack, and that's important to set the expectation of our patients. So my first take-home message, but maybe most of you are at home, so I will call it take-to-work message, or my first counseling tip, is that migraine prevention will not stop the episodes. They may have the same frequency, but less intensity. They will have more efficacy of the like acute treatment, and sometimes it reduces the frequency. And we saw some cases in the first presentation. It's very important to set the patient expectation when we are like dispensing to this patient his migraine prevention treatment. So what are those medications that we use for prevention? And until 2018, those are the medications that were used for prevention. Most of them are off-label, and I have discussed with one of the neurologists this issue. He said all the migraine prevention treatment before the CGRPs were off-label. And that makes me go and read more about them to check if they are all off-label or not, and we will see in the next slide. But most of them will give you 50% reduction. They are effective, but definitely not as effective as the new groups that we are talking about today. So what do we use? I checked if they are labeled or not. So among beta blockers, propranolol and timolol are labeled as migraine prevention, while metoprolol it's not. So when you see in green, it means they are labeled. Amitriptyline, venlafaxine are not labeled, while topiramate is labeled and valproate is not. And definitely all the CGRPs antagonists are labeled. And see, now we have a big group of medications that are CGRP antagonists. While talking about topiramate, I would like to give you again a personal experience. Topiramate is really very nasty drug. When we tried to use it with my daughter, she couldn't, she reached a point where she cannot talk. I mean, her speech, we were not able to understand what she says. So those medications do not come without side effects. So how physicians were choosing their treatments or their preventive treatment before the era of the CGRPs. So if the patient is hypertensive, and I would like you to think with me, maybe we cannot be very interactive, but while at home, try to guess with me. So if a patient is having hypertension, he's non-smoker, and his age is less than 60, what was used for this patient? And we know that we were using beta blockers. While if the patient is smoker and more than 60 years, here we were using verapamil or flunarizine. In depression or mood disorder, and I think that you guessed amitriptyline or venlafaxine. If the patient has epilepsy with migraines, and definitely it's valproate or topiramate. Insomnia, amitriptyline. Now, if the patient is obese, we know that topiramate may help reducing weight, so topiramate is the drug of choice. And if there is renal phenomenon, verapamil or flunarizine. So that's how our physicians were choosing their preventive treatment before the era of the new group of CGRP antagonists. Now, my second take-home message, and it is very important, if you have a patient and he has topiramate, for example, you will not go ahead quickly and tell him this medication is for your epilepsy. You have to keep in mind that those medications may be used for migraine prevention, and make sure that you don't give a diagnosis that may not be the real diagnosis why we are giving this medication. And this was also a comment from a neurologist that sometimes patients are frightened by pharmacists giving them information that take this propranolol, it's for your arrhythmia, for example, or for your blood pressure, while the patient do not have blood pressure. So many migraine prevention medication are not labeled for this indication. They have other indications, while the CGRP antagonists, they are indicated for that, and make sure that you are counseling your patient accordingly. So as we mentioned a little bit, that all those preventive treatments, they have side effects. We discussed one of the side effects of topiramate, beta blockers. We all know their side effects, valproate, the antidepressants. They have drug-drug interactions, many of those. And that's why we feel that we need a new group of medication, and that's what started in 2018. Now, how was it done? It was done, you initiate with the lowest dose, and we know this about propranolol definitely. Then the dose is increased until there is intolerable side effects or the maximum dose is reached. Either it's not successful, but it's important to let the patient wait at least 4 weeks. So here in the old group of preventive medicine, as the doctor mentioned, we had to wait 4 weeks to decide that this treatment is unsuccessful. So if it is unsuccessful, you can try another medication. If it is successful, you can continue for a few months. And then if the patient is stable, you can start tapering down. Now, a very important information I want you to know, that migraine may improve independently of any treatment, and this happens in 10% of cases. That's very important when we read an article or a clinical trial, like if a medication will reduce like the attacks in 15% of patients, while we know that it may improve in 10% of patients without any treatment, then this is important as a clinical information. So now our new group, the CGRP antagonists, when we use them, as we said, if we have side effects, if we have drug-drug interaction, and as mentioned in 2022, they may be used as first line depending on the decision between the physician and the patient, while taken into considerations that they have high cost and sometimes they are not approved by the insurance unless they are second or third line. Another nice information, I remembered attending a lecture about the CGRPs, and a neurologist was talking, saying that while he was a resident, there was a trial, and they took the resident to make this trial. They inject them with a CGRP agonist. So because they discovered this receptor and they gave them the agonist, and that neurologist was saying, I had the worst headache of my life. And he explained that among neurologists, they were waiting for this group of drug to start to be in the market because they knew how much the CGRP receptor, they knew its role in the migraine, as it was explained by the previous speaker. So the first one that was approved by the FDA, it was in 2018. And more came into the market after that. So again, when you think about migraine, you think central nervous system. Just to mention, because we are pharmacists, we like to know about the mechanism of action. The CGRP do not need antagonists do not need to pass the blood-brain barrier to work because they can work from the periphery. Okay, so are they all biologics? Are they all like monoclonal antibodies? No, some of them are small molecules. They are called gepants, and they are taken orally, and those are remigepant and atogepant. And here I have mentioned when they were approved, started from 2018, then another one in 2020, and in 2021 we had the oral form. Now I will go through one by one quickly, and then at the end we will do a summary on the comparison between all of them. So erinumab was the first one to be in the market. It's given either 140 or 70 milligram once per month. This is the one where constipation is a big side effect, and also hypertension. The blood pressure should be monitored when we give it. Framazumab is also a monoclonal antibody. The advantage of this one is that there is a dose that can be given every 3 months. And sometimes that's an advantage for some patients who do not want to take the medication monthly. This is also a sub-Q, and it has a side effect like the injection site reaction only. Galcanezumab, it's also a monoclonal antibody. It has another indication that is worth to be mentioned. It's effective for episodic migraine prevention, but also for the prevention of cluster headache. And that's the only one in the group that is indicated for the prevention of cluster headache. The dosing is a loading dose, and that's why the action is immediate, almost immediate. So you give a loading dose, and then you give 120 every month. So it's a monthly dose, and it's sub-Q, and the injection site reaction is the most common side effect. Now, those three are sub-Q. There is one that we started to use as non-formulary. It's called eptinezumab, and this one is an IV medication. It's IV. Our physician wanted to use it for one patient because the patient didn't want to take sub-Q, and she wanted something that lasts more than 1 month, so they opted for this one that is given every 3 months. But this medication has some side effects like the upper respiratory tract infection and fatigue. So those injectable forms, as I was saying, they are similar in indication, except one more indication for galcanezumab. They are all biologics. They are all very well studied, and they are effective as migraine prevention. As I said, like there is sub-Q, 3 of them are sub-Q, only one of them is IV, and for the indication I already mentioned. Now, for the side effects, as we said, the constipation is major in erinumab, while nausea and dizziness in eptinezumab. What about the small molecules, the oral form of CGRP receptor antagonists. One of them is rimegepant. This one, we mentioned it in the abortive treatment because it can be given 75 milligram every other day for prevention, but also it can be given just for treatment when there is an episode. There is a GI side effect like abdominal pain, dyspnea, and nausea. Atogepant is another one that we don't have here, but it's also in the market. It's oral and it's given in 3 different strengths once daily. It has some side effects in more than around 66%, like constipation, nausea, drowsiness, and fatigue, and upper respiratory tract infection. It takes all the side effects of all of them. So my third take-home message that I didn't mention a lot, but there was a question about it during the first session, is that those anti-CGRP are contraindicated in pregnancy. And that's also very important when you are issuing this medication to a young female. Those medications should be stopped if the patient wants to get pregnant. And the doctor answered your question about what to give and maybe go again for abortive treatments. And sometimes like pregnancy will help into improving the migraine. I mentioned my sister, and my sister, when she married, I mean, this was her prevention. She got much better when she married. So are they all the same? If I will answer the question, no. There are having different route of administration, sub-Q, IV, or oral. The dosage are different, either daily, every other day, or monthly, or every 3 months. They are all used for migraine prevention, but some have added indication like galcanezumab in cluster headache, rimegepant in abortive treatments, and their side effect profile is different. And thank you very much. There is no shukran here. I tried to add it, I couldn't, but shukran, and thank you for your attention.
Thank you, Dr. Marlene, for an excellent, actually, presentation, wrapping up all the monoclonal antibody for the treatment of migraine, and also mentioning our role as pharmacists in the counseling and in the care of patients suffering from migraine diseases. And please allow me to take some questions. So there is someone asking about what is the major drug-drug interaction of atogepant oral, atogepant.
That's a question I will have to look into. We don't have the drug in our formulary. I will have to look into it and I will answer. Drug-drug interaction. We didn't receive this drug, so we can look into that. I don't have experience with it.
Another question, can we combine between two anti-CGRPs?
No, there is no studies, and Maya, you are the expert also, maybe you can help me in that. There is no studies. The question that came to my mind is that anti-CGRP that is used for prevention every other day, but also for treatments. So I thought, I mean, if I took the tablet today, and then tomorrow I have an episode, what should I do? Because I am due for the next day. And I found the answer for this is that 15 tablets per month, so every other day, it's the rimegepant, I think, yeah. So 15 tablets per month, which is every other day. Now, if I have an episode in between, I can take another tablet because the allowance in the clinical study for 1 month is 18 tablets. So the patient can take 1 tablet in between until the prevention is working. You know, the oral medications will take more time to be effective, not like the examples that our doctor gave for the monoclonal antibodies. They are like the onset of action is faster. Yeah, but that's the only example I have.
Another question, can we use those monoclonal antibody for migraine treatment in palliative care settings? So probably in patients with end-stage cancer and they have migraine.
Why not? I mean,
Why not?
palliative care, our aim is to reduce suffering. So whatever we can do to reduce suffering of the patient, we will do. I don't know. I mean, we don't have an example in front of us. Like if we have a case, we may, I mean, it would have been very nice to talk about it, but those patients, they are usually on opioids, on morphine, they are given a lot of medication for pain. If they still have their migraine, then maybe, why not?
Another question, any data or case reports about chest tightness with the use of anti-CGRPs?
Not of what I mean, as I said, I mean, I'm not a neurologist. I cannot say that a patient came to me with those side effects, but from whatever I read, it was not mentioned as a common side effects, at least.
I still have one question.
Maybe Dr. Sorry, if Dr. Bahoucher have a comment.
So if a patient was maintained on a triptan and he wants, or he was prescribed to shift to CGRPs, do we need to have a washout period between the triptans and CGRPs?
No, I mean, triptans, I mean, that's what I tried to explain. When we speak migraine, abortive treatment or prevention. Triptans are like for acute episodes. So the patient will take triptans when he has an episode. So it's for acute. Even if he has often, but it's for acute treatment. He will not take triptan if he is not in pain. So it's an acute treatment. So no, the patient will just start his preventive treatment. He can still take triptans if he has an episode, but the aim, the goal of those preventive treatment is to reduce the frequency, to reduce the like intensity of the attack, so we avoid using those triptans as much as before.
Another question, can we use the triptan concomitantly with monthly CGRP?
Yes, yes. I mean, again, the same. This is for abortive treatment, and this is a prevention. And like, and our way of checking if this is effective is the reduction in how many times we have used our triptans. So triptans is still our like our medication when we have an attack, if it was prescribed. And then now it starts the prevention. And if the patient came back and he said, I was taking like 9 days per month triptans, and now I'm taking 4, then the preventive treatment is working.
Can we use anti-CGRP in lactating mothers?
That's a good question also. That I cannot answer now. Also, we will have to look into it. Maybe you have the answer, Maya.
Yeah. So let me answer this. Please. So although we don't have about their safety in lactating mothers, or in pregnancy, however, usually theoretically, monoclonal antibody, they are very big molecules, and as in multiple sclerosis or in other neurological disease, they do not cross the placenta, and they are not secreted in the breast milk. So in lactating mother. However, we don't have recommendations until today, until we have data from registries and observational probably study and real world experience with this. But theoretically, monoclonal antibody can be used during lactation, giving their very high molecular weight and their large size also.
Yeah, so that's about the monoclonal, but the oral ones, I mean, I opened Atogepant to answer that question. It's not known for the breastfeeding. The question about Atogepant was about drug-drug interaction.
Yeah, what is the major drug-drug interaction?
There is a list, and it's not, I mean, it's not very clear. There is a list of those. Okay, what else?
Okay. a final probably question, if there is any serious hypersensitivity reaction with those monoclonal antibody that can probably maybe lead to anaphylactic reaction?
Anaphylactic reaction, I mean, you make me think about 3 deaths in all the clinical studies about the CGRP that was reported, and it's not clear if it was because of the treatment of CGRPs or not. It is not clear. And it was not from anaphylactic shock, but also, I mean, our experience with those drugs is very short, and I mean, more data will come.
Okay, so it seems, it is the same dose used in elderly for anti-CGRP. We use the same dose in elderly and in young adults.
In those special population, really, there is no, the studies are not a lot in the elderly population. I mean, it's not very recommended to use them in elderly, but the dose would be the same.
Okay, so those were the question. I just looked up the related to chest tightness and anti-CGRP. So please, doctor, allow me to answer this.
Yes,
so
please.
actually CGRP receptor, they are expressed in our cardiovascular system and in the heart and blood vessels specifically, and lead to vasodilation. And they may play a protective role in ischemia, in cardiac ischemia. And there was a large review reviewing the cardiovascular event of anti-CGRP, and they concluded there were no cardiovascular associated with the use of those molecules. On the contrary, they seems to be protective, given that they are expressed in the heart and blood vessel and lead to vasodilation. But also, if you search the literature, there was one case report of myocardial infarction with erenumab. So that's the only case report, but no data about chest tightness or dyspnea.
Thank you, Maya.
So thank you, doctor, again for an excellent session. It's a pleasure to always have you with us. And let us move, thank you, to our last speaker for tonight. Dr. Albert webinar comes to its end. On the occasion of the World Pharmacist Day, corresponding to today, September 25, 2022, the IVPN network family extends its sincere appreciation to pharmacists in all their locations around the world as part a healthcare team that contributes to provide patient care, not only in the neurology setting, but in all the other specialties. Thank you for our esteemed speakers. Thank you, Lily, for sponsoring this activity. And a big thank you goes for you, our attendees, for staying with us until the end. I would like to remind our attendees that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or would like to revisit the lecture, you can check our IVPN Neuropsychiatry library, where we post all the recording. Follow us on our social media platforms and stay tuned for more activities in October. Keep your eyes on our page, as all the details will be announced very soon. Until we meet again, stay safe and have a good night.